am Professor Patrick.
Professor?
Dr. Professor Patrick.
Hey everybody, welcome back. Today we're going to cover the Step 2 Clinical Skills Exam. So we're going to be going over some preparation materials and then some examples that you can do. The learning objectives for today are to understand the history and relevance of the CS exam, to prepare efficiently for this exam. It should not take up the majority of your fourth year. And to know what happens the day of the exam, how to document effectively, and hopefully pass. So a little bit about the history and controversy of the exam. This exam was only mandated for U.S. medical grads beginning in 2004. It replaced the old clinical skills assessment, which was normally a requirement for those who had medical training outside the United States. So some of the controversies, nationally, the student fees account for $36 million. And then over 95% of U.S. medical students pass in their first attempt. So if you kind of hash out the data, it costs about $1.1 million to catch a single student who fails the CS on back-to-back attempts. So it's not a very good predictor. And then despite having 11 years of data, there's nothing to support that a link between Step 2 CS or improved patient outcomes. So in summary, CS is going to be a $1,285 at this time simulated exam. It's offered in 5 locations where students must perform a history physical exam in about 15 minutes and then come up with a differential diagnosis and document that in a note containing about 10 minutes. And there are 12 simulated encounters, and this is a requirement for national certification and licensure. The grading for CS is divided into 3 main domains. There's the communication and interpersonal skills, or CIS, and this is really how empathetic you are with patients, making sure you're providing eye contact, reassurance, the normal doctoring type adjectives that we hear about. Next is spoken English proficiency. So just making sure that you are able to speak clearly, not use medical jargon, and not speak too fast, mumble, or have a difficult to understand voice. And then lastly is the Integrated Clinical Encounter, or ICE score. And this is mainly on your documentation, being that you document clearly and accurately what's going on using medical knowledge, and showing that you used clear medical decision making within your note to form that differential diagnosis and plan. So how to prepare? Obviously, learning from your patients, practicing humanistic medicine throughout your major core clerkships is going to be important. So you want to be able to take a full medical history. So on every patient, you're going to need an HPI, medications, allergies, past medical history, past surgical history, family history, social history, and review of systems. And in doing so, you want to be empathetic. You want to maintain eye contact and have the nonverbal cues so that you can increase your CIS score. But these should be common practice when you're doing your major clerkships. Next, you want to be able to perform a focused physical exam with special test maneuvers depending on the chief complaint. So every patient you're going to examine generally when you come into the room and have a general idea. You're going to do a heart and lung exam, and these should both be performed underneath the gown, so they want direct contact between your hands or the stethoscope and the patient's skin. So if you're doing this over top of the gown, you won't get credit for that. And then you're going to perform a focused exam. So if they have an abdominal complaint, you're going to do a more focused and thorough abdominal exam with maybe some special tests like a Murphy's test or McBurney's point, those type of things. And in doing so, you're going to want to use respect. So always ask permission before you do a test. You want to drape the patient appropriately. So they're going to have a drape in the room. So ask, would they like to be draped or how would they like to be draped? And then you're going to want to be concerned of their pain. So these are simulated patients, but they're going to be acting out various complaints and pains. So if you do, say, a shoulder exam and they say, ow, that hurts, I would not do that over and over again. You want to apologize and empathize with that pain. And then next, you're going to want to develop a differential diagnosis and a plan for these common medical conditions that you're going to see in ED and outpatient settings. So there's a list we'll go over later of the common medical conditions that they'll present with or chief complaints. And you'll want to be able to come up with a plan of at least 3 options of what it might be. And then you're going to want to express that plan with clear language So you're not going to use medical jargon to the patient. You're going to educate and empower the patient, and then you're going to ask for any additional concerns. So before you leave the room, the patient should know what you think it is, what you think the next steps are going to be, and you should have answered all of their questions. And then lastly, you're going to want to write a clear and concise medical legal note. So documentation of the medical decision making behind your differential diagnosis and the workup is very important here. So there are certain cheat sheets or organizers, and this is a good tool to sort of stay on task. We'll talk about these a little bit later when we do an example. So on the day of the exam, before the exam, you're going to arrive hopefully 30 minutes early or so. You're going to check in with the desk staff. They're going to tape up your white coat so that there's no logos or names that might bias the standardized patients. And then you're going to get an orientation to the building, so both the individual room, and you'll get a chance to go through the exam room and test out some of the equipment that they give you. And then you're also going to get an orientation to how the day goes. And you can find all of this information online. So if you're too nervous and you're worried about remembering all those different things, you can actually watch the video that they'll show you before you get to the site. And you'll have 2 time slots that you can get there. It's either an 8 a.m., so an early morning one, until about 3:30 p.m., and a 3 p.m. to 10:30 p.m. for the night owls. And they try and make it so that the morning group is finishing as the afternoon group is already locked into the building, so that there's no cross-pollination, so to say, about the different cases. So you're going to start out with 3 cases first thing. So you'll have 15 minutes to interview and 10 minutes to do your documentation. So there'll be 3 cases back to back to back, followed by a break, and 3 more cases. So you're halfway through at this point, and either lunch or dinner will be provided. I recommend bringing your own food, especially if you have dietary restrictions. And then in the afternoon or night portion, you'll have 3 additional cases, followed by a 15-minute break and 3 final cases. So you'll be doing 12 total cases. It's about 8 hours your day there. And you'll be scored on 10 of these cases. So your lowest case will be thrown out, and maybe one of the cases are experimental or not scored. So if they ask you to do a 13th case or stay late, it's in your best interest to do that, because something either happened or a standardized patient played the case wrong in a previous encounter. So it's in your best interest to do that 13th case. So next, we're going to talk about sort of the schedule of what you should be doing for each of these encounters. So you'll begin by standing up in front of the door, and there'll be a sliding plastic mat that will cover up the doorway instructions. And you'll hear an announcement that says, "Examinees, you may begin your first patient encounter." And you will slide open that information, and you can read the name, age, vital signs, and chief complaint of that case. This would be the good time to jot down whatever organizer you do, along with 3 to 4 possible differential diagnoses. So you would jot down, I had a quick outline that I would do, like 4 scratches across a piece of paper, and I would put chief complaint, old carts, family history, social history, medications, allergies, and everything in the history that I would want to do. And then I would number 1 through 3 or 1 through 4, and I would jot down some possible differential diagnoses to help me organize the review of systems to make sure I asked all the pertinent positive and negative questions you would need. Next, you would knock and introduce yourself to the patient. You can introduce yourself as Dr. So-and-so, as medical student so-and-so, however you feel comfortable introducing yourself. You're going to want to shake their hand, smile, ask them their name, and next you're going to perform a focused history and pertinent review of systems. So you want to cover all the questions we outlined earlier. So each of these are going to be important part of the medical documentation. And then as you wrap up the history portion, you should ask to move on to the physical exam. So you should be moving on to the physical exam before the 5-minute remaining announcement. So as you do your physical exam, you want to sanitize your hands. So this can either be washing your hands, putting scrub on your hands, or putting gloves on your hands. And at this time, usually can be an awkward pause, so it would be good to ask about maybe some social events and try and develop that rapport with patients for your CIS scores. Next, you're going to perform or ask to perform a physical exam. You're going to want to drape the patient if they've got any exposed skins and remove any gowns that they have. And you're going to perform a heart and lung exam on every patient. And next, you'll follow up with a focused exam and special tests. So if they have a musculoskeletal complaint, you can do a full neuromuscular exam for that particular joint, as well as the heart and lungs that you would always do. And then for closure, you're going to ask the patient if they have any questions or concerns. Oftentimes, this is called the challenge question, where they'll ask you, do you think it's broken? Do you think I have HIV? Some type of question that's meant to throw you off and make you think quickly on your feet. And you're going to want to communicate your findings and the plan, and then you're going to thank the patient. It's always good to develop that nice rapport, smile, and your scores might improve a little bit with that. So there is a caveat. There are telephone encounters where you'll go into the room and you'll find that there will be either an iPad or phone available, and you'll just be doing a telephone encounter, so there will be no physical exam. Or there are counseling or caregiver encounters, and this is going to be someone in street clothes per se. They're not wearing a gown, and this would be someone also that you do not want to take off their street clothes and perform a physical exam. You can just observe as your physical exam and offer counseling and plan. So now we're going to move on to an example patient so you can see how this might work out. So they would give the announcement to knock and enter, and at this time you would slide open the patient encounter and you would see it's a 25-year-old named Pat Smith, and they have a chief complaint of night sweats for the past month, and their vital signs are relevant for a fever of 38.0, pulse of 89, respiratory rate of 16, and blood pressure of 118/74. So this is when you can write down in your organizer your HPI, your medications, your allergies, your past medical history, surgical history, family history, social history, including alcohol, drugs, tobacco, and then maybe a quick idea of what you think this might be. So night sweats in a young person, you can think of infectious disease causes. You can think of cancer causes. You can think of rheumatologic causes. So these are some of the ideas that you would want to direct your questions at. So as part of the history for this patient, you find out that this is a 25-year-old medical student, and he presents with 1 month of drenching night sweats that occur every night. He does not feel feverish. He's got a 10-pound associated weight loss and fatigue. In terms of relevant exposures, he recently traveled to the Dominican Republic for a medical mission trip 2 months ago. He's got no known exposure to TB or other specific diseases, and there's been no prior history of TB. He feels that he's had a little bit of fevers but no chills. He hasn't had any cough, chest pain, hemoptysis. There's no cold intolerance, and he's not sure if there's any heat intolerance or fevers. He's sexually active with a single partner, and he uses protection every time. He is not known to be exposed to HIV. He doesn't use alcohol, cigarettes, or illicit drugs. And then on physical examination, you find out that he has a generally well-kept appearance. He's in no acute distress. He's got no rashes or lesions present. In terms of HENT, he's got normal sclera, no exophthalmos. His oral mucosa is without thrush or oral ulcers, and his thyroid is non-palpable. He's got no cervical, supraclavicular, or axillary lymphadenopathy, and his lungs are clear. His cardiac exam shows a normal S1 and S2 without murmurs, rubs, or gallops, and his abdomen is normal, non-tender, no hepatosplenomegaly, and he's got no clubbing or edema. And then on neuro exam, his biceps and patellar reflexes are +2 without any tremor. So just based on these things, we would move on to the documentation section. So I'll open up the practice documentation session and show you how I might fill out this information for the patient. So this is what you're going to see on your computer screens when you come out of the patient room. So it does look like a 1990s Microsoft program, but it does have some easy utilization for you. So I like to start off, since you just counseled the patient on what it might be, and fill in the diagnoses here. So you can fill in TB. It's likely because they were just traveling to the Dominican Republic and exposed to some infectious agents in a third world country. Another one that you can consider is HIV, an acute HIV infection 4 weeks after maybe a new partner, considering that they're an MSM male. And then lastly, a young, healthy male otherwise exhibiting B symptoms of night sweats, fatigue, weight loss. And having these B symptoms would make me think of maybe a lymphoma, like a Hodgkin's lymphoma. And while you're doing these, it's important to move on to the diagnostic studies or next steps for each one of these. So for TB, you can put anything like a PPD, you could do quantiferon gold, or you can do chest x-ray. Either of those would work. For HIV, you can order tests here that you can't perform on an SP. So you could do a GU exam here, as well as a P24 antigen, and maybe a viral load if you're concerned with HIV. And then lastly, lymphoma. You would want to screen for this with maybe a CBC or a CT chest, abdomen, pelvis. Either of those would be appropriate to look for lymphoma. So now that you've filled out the diagnoses and the diagnostic studies of choice, you're going to want to move up and go through your history. So I'll go ahead and type out the history that they presented with as well as physical exam. And you want to keep in mind that there's only 15 lines here. So using something like a bulleted or abbreviated history would be good. Just labeling what you're going to type and then filling in either short sentences or bullet points for each one, trying to stay under that character and line limit. Finished entering the history and physical exam. As you can see, I've got it entered in here. I've used 14 of the 15 lines and about 600 characters, and this is being very brief. So at this point, you would want to start copying and pasting in the supporting historical and physical exam findings. So for a 25-year-old with 1 month of drenching night sweats, the drenching night sweats would be appropriate to put in all of these as historical factors, because TB can present with night sweats as well as an acute HIV infection as well as lymphoma. And then you would want to do the B symptoms as well, because these are all historical findings that you might discover. And then for physical exam, they can often use vital signs. They will put makeup and act out pain in certain situations. They can act out wheezing. They will try and create physical exam findings for you. So an elevated temperature might be found in any of these. And then what I like to include here, you can do pertinent negatives as a way to support alternative diagnoses. So if you had an oral mucosa without thrush, this would be a pertinent negative for HIV, but it would support TB. It would make TB more likely than HIV, or lymphoma more likely than an HIV infection. Just like on history exam, if there is no cough or hemoptysis, the classic signs for TB, this might be pertinent for HIV, making that seem more likely, and lymphoma more or less likely. And you can use the tools here if you're trying to say lymphoma is the most likely diagnosis. You can actually move it up in your differential to be the most likely diagnosis number one, or vice versa. So now that you've filled out the supporting factors, you've got the history and physical exam, it would be hopefully about time to move on to the next case. So next we're going to go over sort of how to prepare and some pearls or keys to success along the way. So here are all the common chief complaints that are listed on the USMLE website. So they've got them divided up into symptoms. So a patient would come in with a chief complaint of abdominal pain, for instance. And I think these are important to go over to, one, know what you're going to encounter on CS. 12 of these will be listed on the door, as well as to practice coming up with a differential diagnosis. So if you could come up with 3 to 4 likely or general categories, I think that would be a good way to kind of hone in your skills on how you're going to both interview the patient and document afterwards with the patient. So being able to come up with those different differential diagnoses for all of these symptoms are important. And then some keys to success. You want to book your CS and your travel accommodations early. It starts filling up almost 5 months in advance. So if you're looking at getting a July or a June date, You would want to book this into December or January, or else those dates might be filled. So if your program has a certain requirement, start to look almost 5 months in advance. And then practice, like I said, coming up with that differential diagnosis for the common chief complaint list, and practice writing notes. So it's important to be able to type fast, know how you're going to document, and have that style done. So the CS website has a link to the program that I just used. It gives you 10 minutes, it times it, and it will auto log out as soon as you've reached the 10-minute timer. So it's important to play with that. And then I think if you're stuck and you need a moment to think, summarizing the information back to the patient is a good strategy. It will improve your CIS score, as well as give you a minute to think. And then, as always, you want to counsel, screen, and empathize with every patient. So if a patient mentions that they smoke or drink alcohol, you would want to counsel them about how that can be disastrous to their health. You want to screen them for depression, suicidality, intimate partner violence, or any other instance if they have that. And then you want to empathize with every patient. So if they're in pain during the exam, if they appear discomforted, for whatever reason, you want to empathize with them, also for the CAS score. But if you get along with your patients, they'll help you out a little bit and give you some hints as to where you should go. And a major key is going to be using Control-V and Control-C. So you can copy and paste when typing. Even though this is a very old and outdated program, it does allow for that, and that's going to save you so much time if you are able to fill out the differential, fill out the history and physical, and then your supporting information. Usually the last 2 minutes I would give myself to copy and paste that information to support my differential diagnoses. And then, as always, you want to be nice to the staff and the standardized patients. So you are paying a lot for this exam. It's going to be a long and stressful day, but it's important to be nice to those around you. They'll give a little bit more leeway, a little bit more direction, and overall it won't be as awful of an experience. So that's it for today. These are the keys for success for the Step 2 CS exam. And keep looking out on the channel as we've got more videos coming along.
I am Professor Patrick.
Professor?
Dr. Professor Patrick.